welcome to Rhythm and Pulse, a conversation with our cardiology physicians. And we are so excited that you've decided to join us this evening. To start things off, I'd like to introduce to you Dr. Tristan Smith, who is the medical director of our cardiovascular program.
Hello, good evening, everyone. Thanks for tuning in, and thank you, Laurie, for the introduction. I'm very excited today to be here with our cardiovascular team. We are on Facebook, we are on social media, and we understand that over the past 24 hours, our institution has been basically in a firestorm of negativity about something that was intended to be good, but was perceived to be not that good, if you want to put it that way. Perceptions matter, but facts also matter. We know that our administration, we know that the Trinity Health System as a ministry is committed to our patients, we're committed to our staff, and we're committed to delivering high quality care. So in the midst of this firestorm as a medical director, I was asked, should we put this program on? It's going to be on Facebook. What do people say? And frankly, I said yes, and I was unequivocal and unwavering in saying yes, because we still have a mission to do. And our mission is to empower people with knowledge about cardiovascular diseases and about cardiovascular health so that they can make the appropriate choices for them and their loved ones. And we can share our experiences and share with the community what we are here for. We're not here to discuss any controversies that may be out there. We understand that people are entitled to their opinions, whether they be founded or not. And I am grateful for this wonderful team that we have at Trinity Health. Our cardiovascular program is growing. Our cardiovascular program, the foundations for this was set by some stalwarts in the cardiovascular field who we have on here tonight. Dr. Nandra, Dr. Smolovich, Dr. McGee, Dr. Murdy, Dr. Sweron, and myself. We joined later on. Dr. Sugar is here. And we have a wonderful cardiac surgery team. Dr. Sekon, Dr. Q, and Dr. Maevsky. And we believe that we do have a lot to offer this community. And we'll continue to pursue all avenues to make sure that the people in our area receive top class quality care as we've been doing over the years, and that we'll continue to do in the future. So I want to thank you all for being here. Let's enjoy this night. Let us enjoy each other. Let us be cooperative in what we do as we hear from all my colleagues and friends. Thank you.
Thank you, Dr. Smith. We do invite you to ask questions in the comments section below at any time during the broadcast. To begin, we'd like to share with you a video of one way that you can help others survive a heart attack, and that is knowing hands-only CPR.
We have the world at our fingertips, inspiration in our touch, and power in our hands. Our hands, gentle enough to hold the next generation, yet strong enough to build movements that can change the world. Our hands can build relationships, frame ideas, and empower communities. We have the ability to share and imagine, create and comfort, love and heal the world around us. And it doesn't stop there. Right here, in our hands, we have the power to save a life. If you see a teen or adult suddenly collapse, call 911 and push hard and fast in the center of the chest.
The power is in your hands.
And our first question is of Dr. McGee. Dr. McGee, how does a person know if they are having a heart attack?
Okay, so thank you everybody for coming. I just want to start today's dialogues and discussion with the foundation, basically about the heart attack and the signs and symptoms and what everybody should be doing when they have any symptoms of that. February is the heart month because Lyndon Johnson came up with this idea in 1963 and first celebrated in 1964 because more than half of all the deaths in men and women in the United States and in the world is from cardiovascular disease. So we got to take control of this. There are a lot of myths. 1 in 31 women die of breast cancer every year, but 1 in 3 women die of heart disease every year. If you were told that you could help prevent breast cancer by following guidelines, how many women would choose to follow them? If you were told that you could prevent the number one killer of women from affecting a loved one or yourself, would you take this to the heart? So women and heart disease, it doesn't affect all women just like men. In the worsening signs for women aren't the same as men. Typical presentation is chest pain, but unfortunately in women, they have more subtle signs of nausea, dizziness, interscapular pain, shortness of breath, some non-specific symptoms. So the presentation of women with the real having a heart attack to the emergency room or to the cardiovascular specialist is always late. So the myth is the heart disease for men and the cancer is the real threat for women is wrong. Heart disease for old people is wrong. Heart disease doesn't affect women is always wrong. I don't have any symptoms. Heart disease runs in my family, so there is nothing I can do about it is also wrong. Threat for women movement advocates for more research and swifter action for women's heart health for this very reason. Again, like I said, women are vulnerable as men. Half of all heart attacks and deaths are in women. Women tend to be delayed longer than men in seeking help. Women do not always exhibit typical symptoms. Again, I reiterate their main symptoms along with the chest pain or shortness of breath, nausea, vomiting, back or jaw pain. Chest pain is, the most of the cardiologists and even the other people know, there are 7.6 million annual visits to the emergency department. Our goal is to differentiate between life-threatening chest pain and common causes of chest pain. There are multiple causes of chest pain that like everybody knows, but always we should think of the worst. It's always better to commit rather than omit. So that's where comes in the program of early heart attack care, what is called EHAC. So the EHAC, heart attacks have beginnings. 600,000 people die from heart attack yearly. That is astonishing number, even all over the world and the United States. Everybody knows what heart attack means. What happens during the heart attack is the blood flow through one of the coronary arteries we supply to the heart get blocked, and they develop over time either acutely or subacutely or immediately or later on. The blockage continues and parts of the heart muscle dies.
Thank you.
What stops a heart attack? Quick action and medical treatment restore the blood flow to save the heart muscles. Our Trinity interventional team is there 24/7. The cath lab is open 24/7, and we are there at any time anybody comes there. Time is muscle. It's very, very important to know the presenting symptoms and to recognize it very early, not to take it lightly. Very briefly, along with the specific symptoms of chest pain, chest pressure, chest ache, chest burning, you should know about the weakness, fatigue, clammy skins, dizziness, nervousness, shortness of breath, neck pain, feeling of doom, pain between the shoulders, non-specific symptoms, particularly in women. which are not recognized very early. Early signs of heart attack and recognition is the key to the common people and also to the physicians in the emergency room.
Thank
Why
you,
do we
Dr. McGee. Dr. McGee, we're going to move on and allow for additional comments.
Yes.
Thank you very much. Does anyone have anything to add from our physician panel to what Dr. McGee has shared? And I would ask that we have one person respond. Okay.
I just want to say one thing, Lori. The Life Simple 7, I didn't get to it. It's extremely important to layman. Get active, at least 250 minutes per week of exercise, control your cholesterol, eat a healthy diet with fruits, vegetables, and grains, blood pressure control, weight control, blood sugar control. Last but not the least, that everybody can do is smoking cessation. Prevention is better than cure.
Absolutely. Thank you, Dr. McGee. So we don't have any questions right now regarding the heart attack from our audience. So we'll move on to Dr. Q. Dr. Q is going to answer the question, what is aortic heart disease?
Hi, everyone. Yeah, and as a cardiothoracic surgeon, we're dealing with the heart and aortic disease on a daily basis. Even though the aortic disease is less than the heart, but it's still very severe, serious disease. It can have a devastating result if we don't pay attention and treat it. Okay, so aorta is the largest blood vessel in the body. Then although the aorta is a tough, durable workhorse, as we all know, is deliver the blood to all over the body. But sometimes the wall can be weakened or bulging out. We call the aortic aneurysm. And it can become layers. We call the aortic dissection. It can have the ulcers from the atherosclerotic disease, which can cause we call the penetrating ulcers. And also sometimes you can have a trauma and an injury. We call traumatic aortic disease. But today, and it is a variety of the large scale of this disease. We're focused more on the aortic aneurysm. So this is something we can try to avoid, and try to prevent it from happening. So, so in that case, and if you have the family, like family has a Marfan's disease or any connective tissue disease, and or aneurysm running among your families, you really have to ask your doctors to measure the diameter of your aorta. In that way, check to see if you have any aneurysm is growing, and also have the whole family and to have a follow-up and to check it out. And so this is basically is the most of the time they are found by accident when your doctor is checking in your heart or get a chest X-ray, CT scan for any other reasons. And it can happen in the chest, we call thoracic aneurysm, or it can happen in the abdomen, we call abdominal aortic aneurysm. So, and if it's happening emergently, it can have like a leaking and or rupture. It can cause a severe chest pain, or in the abdomen, it can cause the abdominal pain, and it can have a back pain as well as a presentation of this disease. It can grow slowly without any symptom as well, and without knowing it, then you could have the sudden rupture if you don't pay attention to it. So, and if you have symptom, chest pain, back pain, jaw pain, and so the treatment is the surgery. It can be the open abdomen or chest, open repair, or, and of course, it depends on where the problem is, how severe that is, to remove the bulging in the part of the aorta and replace it with a fabric tissue we call the graft. or a newer, less invasive procedure we call endovascular repair. That it is basically called a stent graft. Through the growing of the side, it's just to replace aneurysm to cover it. And this is stent graft inside the water with lessen the pressure and to repair the weakened aortic wall. So, and after a month or 6 weeks after surgery, you should be able to resume your normal activities. So this is a potentially devastating and lethal disease. And how do we do anything to prevent it? So, and however, if your aneurysm is small, your doctor may not do anything and prescribe any medicine for you to do. So there's a certain lifestyle, as just Dr. McGee mentioned about it, is important, not only for the heart, for the aorta as well. Like quit smoking, change your diet, reduce sodium and cholesterol, and avoid strenuous activities. And do not put too much stress on the aorta if you already have one. And control your high blood pressure, reduce the stress. And also the blood sugar control. And sometimes the dental and oral search and hygiene is important because those patients tend to have a higher rate of endocarditis, the infection of your heart. And also screening your family member as well. So as been said, it is the type, we have two types of actually several types of aortic aneurysm. For the aortic dissection, they have two types. One is type 1, it is emergency, and that had to have repair surgically, and emergency surgery is required. The type B is below the arch, we call it descending to the rest of the water. That sometimes can be managed medically. So, and has been said, and all those aortic disease, it is very important you follow it up, especially you have the family member, and then you should have a screening and for the first degree or first degree relative to check it out.
Thank you, Dr.
Also,
Q.
yeah, okay. All right.
Thank you, Dr. Q.
Any questions?
We are going to change the format just a bit, just to let the physicians know. We will not do any rebuttal questions. In the interest of time, we're going to try to move through the questions that we already have so that everyone gets a chance to speak. I would remind our physicians that please try to keep your comments as brief as possible, 1 to 2 minutes, please. Our next physician is Dr. Nandra. And Dr. Nandra, could you please explain to us what is broken heart syndrome?
Well, thank you for the invitation. I think it's a very important question. I think very relevant question at this time. It is, first of all, it's Women's Heart Month, and also because of the COVID stress in the nation, the incidence of a broken heart syndrome or Takotsubo cardiomyopathy has increased to two to three folds. And this disease predominantly affects postmenopausal women, and 90% of it is in the female gender. And it is a disease of the heart muscle due to temporary weakening of the heart. Most of the time it is due to negative emotions or physical stress. Negative emotions predominate in women and physical stress in men. This results in the release of enormous amount of stress hormones, including adrenaline, that stuns the heart muscle, giving it an appearance of Takotsubo, which is a part that the Japanese used to trap the octopus. And symptoms are very much similar to what happens when people have a heart attack, namely chest pain, pressure in the chest, heaviness, shortness of breath, palpitation, even passing out. And when the patient comes to the emergency department with these symptoms, an ECG may show that they are actually having a heart attack, and the chemical tests that we do, namely troponin, etc., are often elevated, giving us an impression that the patient is actually having a true heart attack. However, when we subject these people to a left heart cath or selective coronary angiogram, the coronary arteries do not have any significant blockages. Good thing is that 95% of these people recover within a few months, and 2 to 4% actually die. And very few have what they call chronic Takotsubo syndrome, manifesting as chest pain with exertional shortness of breath, palpitations, and just fatigue. And treatment is pretty much standard with beta blockers and ACE inhibitors, the drugs that we use to treat other form of cardiomyopathies and uh, weak heart. Thank you.
Thank you, Dr. Nandra. Our next physician is Dr. Ramana Murthy. And Dr. Murthy is going to speak with us this evening.
Good evening. Thank you.
Pulmonary embolism.
Thank you for the invitation, and also thank all the members of the community participating in it, and all my cardiovascular and thoracic community professionals along with us. So Dr. Mays is going to talk more about the deep vein thrombosis. That's a part and parcel of what I'm talking about, the pulmonary emboli. We have this problem for years and years, and most of the time, either with hematological disorder, trauma, post-op like a knee surgery, hip surgery, and the abdominal surgery, increase the risk of thrombus formation in the lower abdomen and also in the lower extremities. Some of those clots can get into the arteries in the lungs. That's what we call the pulmonary emboli. That immediately increase the risk of low oxygenation, shortness of breath, even respiratory failure, end up either putting in a BiPAP or putting in a ventilator. That has brought into much more light recently with the COVID patient, increasing the risk much higher. We've seen a lot more during this period. So, and I think a lot of time, not only they get very sick, short of breath, not able to breathe, not properly oxygenated, and they may get irregular heartbeats too, like an atrial fibrillation, rapid heartbeat, and also unable to do anything. Sometimes they collapse and they pass out, and they're able to get to the hospital. And as Dr. McGee said, the care is available 24/7, and both our colleagues and leadership and the hospital is trying to provide the excellent care for last several years, and we are one of the focal center in the surrounding areas, covering about 8 to 12 counties. So this catchment area is good. We're trying to help the community as well as possible. When the patient come in with this large burden of the clots in the arteries and lungs on both sides, and unable to breathe, that increase the strain on the right side of the heart. We identify it, we do the proper testing. Since the lack of available time, we're trying to make it very brief. And then we do the appropriate testing and document these are certain patients to get the benefit, taking to the cardiac cath lab. And now the leadership is looking into a lot of modern equipment to extract the clots out and to check the pressure. Sometimes the pressures in the lungs markedly increase. If we do the intervention, taking the clots out, and a catheter base clot buster, like your sink is clogged up, you do the Drano, and it dissolves, and your sink is open up nicely. Same way, what the catheter based thrombolysis clears it much faster than regular anticoagulation of the heparin and other oral anticoagulants. And actually recovery is much faster, a lot easier. And then we put a filter in the lower part of the, the right around below the, where the renal veins are there. And that umbrella opens, and then you won't allow the clots to go from the lower abdomen or lower extremities into the lungs. So that will prevent it any further. But those things can be taken out when the surgical aspects getting better. They're more ambulatory, and whatever the cause for those clots are taken out with all the precautions and everything, and then the filter can be taken out. So, and any hardware, it doesn't belong there. We should not to keep it there. So that's what basically it is, and the care is given extremely very. Quite a few of us can do this procedure, so available at all times, 24/7.
Thank you, Dr. Murty. The second part of that question was, why has there been an increase with COVID and pulmonary embolism? Can you briefly explain that?
I think that increased the risk not only for the clot formation in the lower extremities and the lower abdomen, that clot burden, but also we're seeing a lot of increase of pneumonia that also increased the risk, and has also affects the cardiovascular system, and COVID affects the multi system and increase the mortality morbidity. One thing I had to admire, the leadership and the medical staff as a team has done extremely good. And briefly to say, like a lot of our hospitalists, like Matt Corflesh, and also we have the excellent pulmonologists like Dr. Aziz, and also Ken Wood as an infectious specialist. They've done extremely well in taking care of these patients, and we get a lot of patients from surrounding hospitals and community as a center, for taking care of these patients. So I admire our colleagues, my admiration and clapping for them. Okay.
Thank you, Dr. Murty. And Dr. Victor Majewski will now address DVT and veins.
Thank you for the opportunity to be here tonight. My practice is very broad, and we've been practicing in Nevada for about 14 years, includes cardiovascular, thoracic, and vascular surgery. However, I volunteered and took a liberty to talk about the vein disease because I believe that the vein disease was much underestimated for many years in medicine. When people talk about peripheral vascular disease and venous insufficiency, those two terms sometimes exchange incorrectly by the laymen and laywomen. The vein disease, particularly deep venous thrombosis, is disease which we see more and more frequently nowadays with COVID-19 infection, as Dr. Marty just mentioned, because it affects microvasculature. In fact, one of the treatment modality for the COVID is to be on systemic anticoagulation or blood thinners while patient remains in the hospital to prevent clots. For the last 2 years, we've started seeing more and more people presenting with deep venous thrombosis, which affecting the veins of the lower extremity, as well as veins in the pelvic area, as well as the abdomen. There is multiple modalities of the treatment for the deep venous thrombosis. We're not worried about much of the discomfort or appearance of the lower extremity when somebody develops deep venous thrombosis. We're worried about pulmonary embolism, as Dr. Morty just mentioned in his presentation. However, deep venous thrombosis cause very long-term sequelae, such as venous insufficiency. Initial treatment for deep venous thrombosis includes blood thinners, orally or intravenously, or subcutaneously with heparin, Lovenox, warfarin, Eliquis, or Xarelto. The treatment usually lasts for between 3 and 6 months, depends on severity of the affected lower extremity or presence of pulmonary embolism. If somebody presents with significant bilateral or both sides of the lower extremity affected with a deep venous thrombosis, and they have a pulmonary embolism, sometimes there is an indication for insertion of the retrievable inferior vena cava filter, which is the screen, as Dr. Morty mentioned earlier, which goes into one of the main veins in the abdomen to prevent further clot to advance into the lungs and cause long-term disability as far as right ventricular failure and so on. The deep venous thrombosis unfortunately causes long-term sequelae for the lower extremity as well. It affects the little valves, which we all have, We were created by God walking on two legs, and the blood has to get back to the heart against the gravity. When somebody has venous thrombosis or other underlying problems which affects those little valves, they become incompetent. Instead of the blood going back towards the heart against the gravity, the blood sits in the legs, affecting the valves and cause severe congestion and swelling of the legs. Initially, it can be treated by leg elevation, introduction of the water pill to get the swelling down. However, the main treatment, when somebody develops varicose veins and some problems related to that, such as ulcerations, discoloration of the leg, would be to be more aggressive, which the treatment was underestimated for years, and eventually, for the last 10 years, became standard of care. The treatment is consistent of wearing compression stockings as the conservative approach to the problem for 3 months. Then we can approach the same patient with the minimally invasive technique and endovascular techniques such as the laser ablation, injection of sclerotherapeutic agents as well, which divert the flow from the superficial venous system into the deep system and provide significant relief. The symptoms of the venous insufficiency or venous thrombosis include swelling of the legs, pain and discomfort, itching, discoloration, and presence of ulcers. The treatment and modality significantly improved for the last few years, and I'm very happy and proud to be part of the Trinity team to provide all kinds of care for venous disease. Thank you very much.
Thank you, Dr. Majewski, and welcome to the Trinity team as one of our newest members. At this time, we'd like to welcome Dr. Gregory Suero, who is going to talk a little bit about menopause and heart disease.
Thank you, Lori. Good evening, everyone. I think that's a very important topic to touch on because menopause is a non-modifiable stage of every woman's life. At some point, every woman is going to experience menopause. During menopause, your body's going to go through a lot of metabolic and psychological changes. It is well known that estrogens confer some degree of cardioprotection. And when you get to menopause, with the withdrawal of the estrogen, that cardioprotective effect, unfortunately, it starts to vanish. The changes that you can see from a metabolic perspective, there's a lot of inflammation. There's what we call endothelial dysfunction, where the blood vessels don't work like they should properly work. That will lead to increase in blood pressure. It will lead to increase in your cholesterol levels, and also what we call glucose intolerance, where your body cannot handle your blood sugars properly. In addition to the metabolic changes, then we have the psychological part of it, the hot flashes, the mood swings that can lead to depression. It can lead to anxiety, which we know are also risk factors for cardiovascular disease. So if you experience those changes, and then on top of that, you already have those risk factors, you're already a smoker, you're already overweight, you already have hypertension, you already have high cholesterol, you already have diabetes, then these effects multiplicate. So they multiply. So now you are multiplying your risk factor for coronary artery disease or any cardiovascular event. I said menopause is non-modifiable because there's nothing you can do about it. There's nothing woman can do about it. It will eventually happen. But the things you can modify is monitor your blood pressure on a regular basis, check your cholesterol on a regular basis, exercise, try to lose some weight, quit smoking, talk to your physician and your primary care provider about anxiety and depression. It is important because the statistic is very high. It's 1 in 3 women. Menopause eventually will happen, and those changes will come along with it. So the time to prepare and change to prevent that is today. It's not tomorrow. It's not when I get to menopause. You need to start preparing now. Thank you.
Thank you, Dr. Suero. Appreciate that very much. This evening is brought to us by Warwood Media. So we would like to say thank you to Warwood Media for sponsoring our panel this evening as part of our Go Red activities during the month of February. Our next physician is Dr. Rafael Smolovich. And Dr. Smolovich is going to talk to us a little bit about angioplasty and stents. Dr. Smolovich?
Thank you for inviting me, Lori, to participate in this discussion panel. I think all of us do nowadays procedures that are from simple to complex, and what I wanted to share today was how all these started, because not too long ago, like 50 years ago, when patients had heart attacks, there was not much that physicians could do to save patients' lives. In those days, patients were treated with medications like morphine, oxygen, heparin, amyl nitrate, and a lot of bed rest. Patients would stay in the hospital for in bed for several weeks. We've come a long way since then, and now we can open arteries in less than an hour, saving patients' lives and decreasing the chances of heart damage. I wanted to share 3 historical moments in the world of cardiology that are important, and were the solid base that allowed us to perform these procedures now. The first event was in the year 1929, when a doctor named Werner Forsman from Germany came up with the idea of putting a catheter in the heart to deliver medications. This was at that time a very radical idea. He thought that nobody would let him do that, and he enlisted his nurse, Miss Ditson, to help him. And one night, when he knew that there was nobody in the operating room, he went with Miss Ditson to the operating room. He made a cut in his elbow after putting some local anesthesia, and inserted a urethral catheter into a vein and advanced it into the right side of the heart. This was the first time that somebody had tried a procedure like that. It was the beginning of what we call today a heart catheterization. In that case, was a right heart catheterization. This procedure was then later on picked up by 2 other doctors from Columbia University, Dr. Cunard and Dr. Richards, who refined the technique, and at that time started to make pressure measurements in the heart. All these 3 gentlemen, Dr. Forsman, Richards, and Cunard, they won the Nobel Prize in 1950s for Nobel Prize of Medicine for their achievements. Later on, there is another historical moment, and it belongs to another brilliant doctor with a brilliant mind, Dr. Mason Sones. Dr. Sones joined the Cleveland Clinic in the year 1950, and he developed a technique to go through the brachial artery with a catheter that has his name, the Sones catheter. And he was he has a lot of manual dexterity, and was able to go into the aorta to take nice pictures of the aortic root. During one of those procedures, the catheter inadvertently flipped into the right coronary artery, and contrast was injected in the coronary artery, and that was the first time that a coronary angiography was performed. It was a scary moment, because it was thought at that time that injecting contrast in one of the coronary arteries would make the patient have cardiac dysrhythmias like ventricular fibrillation, because the contrast was not oxygenated blood. To his surprise, the patient survived, and that was the beginning, in a way, of what we call today a left heart catheterization. And the third historical event was by a doctor from Switzerland called Andreas Grunzig, who came up with the idea of putting a balloon on the tip of a catheter in order to try to open occluded blood vessels. His first patient was a man who had significant intermittent claudication and severe leg pain. And the patient did not want to have surgery, and he convinced the patient to have this procedure, and he advanced the catheter with the balloon tip and opened a blockage in his leg with relief of the patient's symptoms. He then applied the same technique years later to perform the first coronary angioplasty. That was done in 1977 in a 38-year-old insurance salesman who came in with chest pain. He had been taking nitroglycerin several times a day, and he refused the standard treatment, which was bypass surgery at that time. So Andreas Grunzig took him to the cardiac catheterization lab with the surgeon standing by, and he went through his groin, through the femoral artery, advanced the catheter, and then managed to put the balloon where the blockage was, inflated the balloon for 15 long nervous seconds. The patient remained pain-free, and the EKG did not change. And that was the first time a cardiologist was able to open, in that case was a blockage in the left anterior descending artery, the main artery of the heart, what we call a widowmaker nowadays, and the patient did well. In fact, 10 years later, after the first procedure, Dr. Grunzig took the patient again to the cath lab, and the artery was still open. So those three events were the base for all of us to perform these procedures. Obviously, after Dr. Grunzig did that, a lot of doctors from all over the world flew to Zurich to learn that procedure, and now we are very grateful for those brilliant minds to have developed the techniques that allow us to do these procedures and save patients' lives.
Thank you, Dr. Szmulewicz. That was very interesting. We're learning so much tonight with our physicians. And again, I would like to thank Warwood Media for being our sponsor of this evening's broadcast. At this time, Dr. John Sugar, our congestive heart failure specialist, is going to explain to us what is congestive heart failure and how is it treated. Dr. Sugar?
Yes, thank you very much, Lori. And I'd like to thank you for putting this event together, and for our sponsor as well, and to my colleagues who've eloquently spoken on a number of topics today. I'm grateful to participate with all of you, and to those of you who are asking questions and watching, thank you for your time, and I hope that we can be helpful. Heart failure could be described simply as either the heart not pumping well, not squeezing well, or perhaps not relaxing well. Most commonly, I think people think of heart failure as the pump or the heart not squeezing well, and there are a number of causes of that. It's important to recognize that if the heart doesn't relax well, that can be due to hypertension, and in this month when we're focusing on women's heart health, it's important to remember that women tend to have what's called diastolic heart failure, or heart failure with preserved ejection fraction, more accurately, more commonly than men, and it can be serious, and hypertension is a contributor to that. So as some of my colleagues have already mentioned a few times tonight, getting risk factors controlled, such as hypertension, is important. Heart failure presents whether it's due to a relaxation abnormality or a squeezing abnormality with shortness of breath. It can present with swelling in the legs. It's also important to remember that there are other causes for these symptoms, right? So it's important to visit with your doctor, visit with us to help define what the cause of the symptom is. But shortness of breath, swelling of the legs, fatigue are common presentations of heart failure. If we look at what's called systolic heart failure, or the heart not squeezing as well as it should, there are many causes. My colleagues in interventional cardiology and have discussed the importance of presenting early to the medical establishment when you have a myocardial infarction or a heart attack. We've discussed angioplasty, opening up the blood vessels of the heart. And ischemic heart disease is a very important and frequent cause of reduced heart function. Hypertensive heart disease is another cause. Valvular disease, and we are developing an excellent valvular heart program here at Trinity with the leadership of Dr. Smith and Suero, intervening outside of surgery, intervening in the cath lab on aortic valve disease and hopefully other valves as well. So valvular heart disease. There can also be infiltrative causes where proteins are deposited in the heart muscle. And very commonly, we see what is called idiopathic dilated cardiomyopathy, which is a fancy way of saying that we don't necessarily know what caused the reduced heart function. The important thing to remember is that it can be treated. Heart failure sounds scary. It should get our attention. It does lead to symptoms that I've mentioned. It does lead to increased mortality, unfortunately. Fortunately, it can be treated. And again, with the help of our colleagues in the cath lab, with the help of our surgical colleagues for bypass and intervening on valvular heart disease, with the help of our colleagues in the cath lab, intervening on valvular heart disease in the cath lab, we can make improvements in the heart often. There are medicines we can use. There are medicines that we can use to improve heart function, prolong life, increase heart function, improve symptoms. And that's a process that requires some time, and it's several medications. Just to very quickly mention them, beta blockers and medicines that treat the renin-angiotensin-aldosterone system are the most common medicines. Now there's some diabetic medicines used for that as well. And there are a couple of others. But the good thing is, by intervening on a problem, if there is a problem with the blood vessel or with the valve, by using medicines, sometimes by using what's called the biventricular pacemaker, we can improve heart function, we can prolong life, we can improve symptoms. And so we're working to manage and treat, and in some cases to reverse heart failure and help people recover from it. One last thing, when these approaches don't work, it's important for patients and their family members to remember that there are other options, advanced heart replacement therapies, options such as transplantation or heart pumps. And we can certainly help with the initial diagnosis and giving an opinion whether patients might be candidates for that in the future and refer them to appropriate centers. So thank you again very much, all of you, for your attention. And just like to close with the fact that while heart failure has many causes and is a serious condition, it can be treated and there's hope. So thank you very much.
Thank you, Dr. John Sugar. And we are getting ready to start a heart failure clinic with Dr. Sugar in the very near future. So please watch for information about that coming soon. At this time, we're going to welcome Dr. Tristan Smith back. And Dr. Smith, tell us a little bit about TAVR, a new procedure being performed at Trinity Health System, what it is, and when is it indicated?
Thank you, Laurie. And thanks to everyone who participated tonight. This has been very, very informative and very educational. And I think we all gleaned a lot from it. It's an exciting time to be in cardiology, to be in interventional cardiology, and to be in what we call structural heart cardiology, because we're now able to do a lot of really cool things, cool in quotation marks, for patients which were not available even 5 to 10 years ago. And one of those things is TAVR, which is transcatheter aortic valve replacements. Now, as we age, whether we're male or female, the aortic valve, which is the major valve, the valve that allows blood to leave the heart to get out into the body, it takes a lot of wear and tear, during one's lives. And remember, the heart squeezes between 60 to 100 beats every minute. So that blood is going across that aortic valve, and it causes the aortic valve to become damaged. Then calcium deposits there. The valve itself becomes very thick and calcified, and it doesn't open well. And we all know that the function of valves is to, allow one directional flow of fluid. So when the aortic valve becomes very narrow, the blood pressure builds up within the left ventricle, and that causes the left ventricle to become stiff and hard, and patients develop chest pain, shortness of breath, they can pass out, etc. So the treatment for that, we all know if there's an obstruction somewhere and if there's a valve that's not working well, the thing we do is to replace the valve, right? And traditionally, to replace the valve, we had to go under general anesthesia, open up the chest, take the valve out, and get a new valve, put it in, sew it back up, and rewire the chest. And that worked for a long time, and it still works in a lot of people. But we realized that there were some people who just couldn't undergo open heart surgery. And the smart, ingenious people figured out a way to get a valve onto a balloon and get that valve into the aortic position, open up the balloon, and have that valve that's mounted onto the balloon expand in the old aortic valve, and the balloon is then deflated, and that new valve takes over the function of getting or allowing the blood to leave the heart. So that's TAVR, transcatheter aortic valve replacement. It's replacing the aortic valve without needing open heart surgery. We typically go through the groin into the femoral artery. We put a large catheter in there. We're able to mount the valve onto the balloon. We get it up, and under rapid pacing of the heart, we deploy the valve. Now, it sounds simple. There's a lot of steps that goes into this. We have a valve clinic where we see our patients. All patients are screened appropriately. And we have a multidisciplinary team. We discuss all of these patients, Dr. Sugar, myself, Dr. Suero, Dr. Sekon, Dr. Maelski, Dr. Q, and any of the other cardiologists who want to come on board. We meet, we discuss the indications, we discuss what's best for this patient. We say, based on the patient's profile, based on the risk of that patient, is that patient a better candidate for open heart surgery, or is that patient a better candidate for transcatheter aortic valve surgery? And based on our recommendation, we speak to the family members and the patient, and we proceed. This is a very minimally invasive procedure. Our typical length of stay is 24 hours. Patient comes in, get the valve done, and go home the next day, and then follow up in a valve clinic for the appropriate follow up with echocardiograms, etc. So this has revolutionized the way valve pathologies and valve treatments is delivered. Many more patients are being treated with transcatheter aortic valve replacements because now we can do inoperable patients, high-risk patients, moderate-risk patients, and patients who are also at low risk. They can all get this therapy that is safe, effective. It allows for immediate ambulation. There's no significant downtime. So patients also like this approach to treating their aortic stenosis. There are some patients who will not be candidates, and if they're not, then we go ahead and do open heart surgery and replace the valves. So transcatheter aortic valve is basically that, replacing the aortic valve with one that's on a catheter. There are lots of other new and exciting things that are coming our way at Trinity. We'll be starting our left atrial appendage occlusion program pretty soon. We'll be also launching programs where we can treat the mitral valve as well as the tricuspid valves using transcatheter-based therapies. So stay tuned. We're here for the long haul. We're here to give you the best therapies and the best treatments that are out there. Your hearts will be in good hands.
Thank you, Dr. Smith, and thank you to all of our physicians this evening. We do have a question from the audience for Dr. Scherger. The question is, why is it so important for people with congestive heart failure to be followed more closely?
Thank you. Thanks for that very good and insightful question. I think first of all, it's important for all patients who have cardiac pathology to be followed closely in different circumstances. And certainly I can let my colleagues speak to that if others would like. But from a heart failure perspective, it's a disease that often has a stepwide incremental decrease in function or worsening in heart function. Now, again, as I said, that there's a lot of hope with both interventions and with medical management that we can improve and lead to heart recovery in some cases. And if we don't, there are other options such as transplant and LVAD where we could refer for patients for. But it is a disease that tends to progress over time. And early on, when you're treating heart failure, it's very, very important. I mentioned the medications that we use to help reverse heart dysfunction or hopefully improve heart function. And it's very important. Others have mentioned the importance of timeliness in intervention in cardiac disease. And it's the same in heart failure. It's important to get those medicines started early. It's important to regularly and frequently be increasing them to goal doses. And it's important that we see our patients and prevent worsening or decompensation that can lead to hospitalization. So I hope that answers the question. And again, thank you for that question.
Thank you, Dr. Scherger. We do have a question from Gates Roxanne. Is there a time that a woman should have a stress test even if she's not having symptoms? Who would like to answer that question?
Am I on?
You are.
The straight answer to that is no. If you're not having any symptoms, then you should not have a stress test. That being said, we understand that women can present with heart disease in very varying form. And when I say heart disease, I mean coronary artery disease. Sometimes the symptoms are not typical symptoms. So in the strict sense of the word, no symptoms, if the symptom is chest pain or arm pain, then no, there should be no stress testing if the patient is asymptomatic. However, with females, we've noted that sometimes there's a little jaw pain, and that can represent their symptom for coronary artery disease. Sometimes it can be a little shoulder pain. Sometimes it's just shortness of breath. So having that consultative dialogue with your cardiologist, that cardiologist should be able to pick up on these signs that would be signs or symptoms that would otherwise go unnoticed, and then that might prompt the cardiologist to do a stress test. But in the strict sense of the word, if there's absolutely no symptoms, there shouldn't be a stress test done.
Thank you.
And also,
Can I add
let me add that.
Yes, Dr. McGee.
And also, I agree with 100% what he said. But even if you don't have that much symptoms, if you have significant risk factors, particularly in women and diabetics, we miss many times the real signs of a heart attack happening, or what we call the acute coronary syndrome, early onset and stuff. So if they have significant risk factors like obesity, diabetes, hypertension, hypercholesteremia, tobacco abuse, those are the ones. It's not a bad idea in men above 45 and women above 55. If they are really concerned, strong risk factors, particularly family history and the other ones I mentioned, not a bad idea. If they are concerned, we may even do just an EKG, and if there is any silent ischemia or anything like that, not a bad idea to do a stress test.
Thank you, Dr. McGee. This question comes from Nikki Belcastrolenko, and she is asking, what is a normal effraction rate?
The ejection fraction, you mean?
That,
Dr. Shergar may be the best one to answer. That's his field.
Yeah, no, again, thanks for thank you for the good question. I mean, it's important to know that from a patient standpoint, from a family member standpoint, and oftentimes, patients are confused by this relatively simple concept, and I think it's important that we explain it well. So, the simple answer is that a normal ejection fraction is 55 to 65, 55 to 70%. Some people might say 55 to 75%. What does that mean? That means the percentage of blood that goes into your heart, that's into the left heart in particular, that's ejected out of the heart. Just to follow up on earlier comments, though, that I had the opportunity to make, a normal ejection fraction, again, doesn't necessarily mean that a patient won't present with symptoms of heart failure. And again, in this month, when we're focusing on women's heart health, it's important to note that women are more susceptible to developing diastolic dysfunction. That's a relaxation abnormality of the heart. And if they present with symptoms of heart failure, then that's something known as heart failure with preserved ejection fraction. And that can be challenging to treat, but the mainstay of treatment of that is good fluid balance control and good blood pressure control. And now medicines are beginning to slowly emerge that might help, at least with helping to keep people out of the hospital. So it's a good, thank you for the question. It's a good question. It's an important question to have an appropriate understanding of.
I think, hello, Nandra. I think many times I've come across patients where when you say your ejection fraction is 60%, they get shocked. They think it's supposed to be 100%. I think it often serves a good way of telling the patient the 100% is not normal. And I think people are kind of believe that 100% is what it should be. And unless you specifically tell them 55, 65, 70% is normal, they misconceive this and they worry about it.
Good information.
That's a very good point, Dr. Nander.
So we do not have any additional questions. Do any of our physicians have anything additional that they would like to add before we close for the evening? I will tell you there are lots of comments in the social media thread telling us that they loved this, our community loved this, and would like to see more of this. And
I just want to make one comment about this Takotsubo cardiomyopathy. And there is also a thing called happy heart syndrome. When you are exceedingly happy and there's some jovial, you still get a lot of stress hormones that are released, and that can cause Takotsubo cardiomyopathy. It's not a happy event, but it does happen.
uh-oh. Thank you for that, Dr. Nandra.
Similar to holiday heart.
I guess it's important to stay even then, right? Not too happy, not too sad.
Well, they say perpetual happiness is a sickness.
So I think, in the Lori, as a general thing, all the wonderful cardiologists spoke eloquently and had a great time. I think that Trinity and we all are all excited to have the new team with the new procedures that we have, that we don't need to send the patients out, and not just with the valvular disease, and they're doing the TAVR, and of course they're going to be extending it to mitral valve clips and mitral clips and appendage closure and all those things. Very high risk interventions now with that Impala device available in Trinity with interventional cardiologists. I think they're providing almost all kinds of cases can be done at Trinity, and I think the community should make use of this. And there is no reason to go to tertiary care unless that we tell them that they need to go. Even a lot of my patients, which I need to send out, they're able to do it here. It's a blessing to this community.
Thank you, Dr. McGee. On behalf of Trinity Health System, if we have no further comments.
Yeah, I would like to make one further comment before we end.
Absolutely.
I've always stated this, and I will state it again, that this cannot work, and this will never work without us being a team. We have a great team of physicians, but we also have a great team of staff. We have some staff in the cath lab who are absolutely phenomenal, who show up, who are very knowledgeable about what we do, because without them, we will not be able to do our jobs. We have a wonderful set of staff in the cath holding area, in the echo department, in the nuclear cardiology department, and in the offices. Now, it has been a very difficult time with COVID, and everyone has had to adjust schedules, etc. But the whole cardiovascular team, from administration to the physicians, to the nurses and techs, have been very, very good throughout this whole process. And I would just like to thank them all as well for everything that they've done to make sure that we can continue to provide the top-class care to the patients as we are doing every day.
Thank you, Dr. Smith. And thank you to all of our physicians for joining us. Thank you to everyone who tuned in this evening to watch and submit questions. And we will be doing more of this, and we look forward to seeing you soon.
Thank you.
Thank you.
Thank you. Thank you, Laurie.
Thank you very much. Good night,
Wonderful
everybody.
job. Thank you.
Okay. Thank you.